look for an update from the Department of Health. Then also, we heard from the Office of Mental Health, and no one was able to participate today from there. I think they might have been having a holiday party, which is kind of typical, right? No updates from OMH on this call. I think Mariah, is Mariah on there? Do you see her? No? I think Mariah will be joining us from Excellus, and she has an answer to a question that came to us actually through the Northeast Telehealth Resource Center. So we'll answer that question. I did want to kind of do a quick update, some thoughts on some legislation that recently went through, and then really just hear from you guys. I know when I sent out the agenda, I also asked the question, what do you think the greatest achievements for telemedicine in New York State last year were, and what are your expectations for telemedicine in New York State for the next year? So be thinking about that as we come to it, and we'll look for your participation on that. So let's see, anybody from DOH? See a hand raised? Just kind of scroll down there and there'll be a little hand in the fourth column. Oh, so maybe DOH is having a holiday party too. Yeah, it could be.
And there's no way.
Okay.
Oh, Mariah.
Let's see, any questions that maybe we want to propose to DOH or OMH in January? If you want to make a comment on that, go ahead and raise your hand.
Hand raised.
Who's that?
I clicked on it.
Is that Judy?
Yeah, Judith.
Hey, Judy.
Yes. Hi, David. How are you?
Good. How are you?
Good. I was sort of hoping that DOH would be here, but
Yeah.
I just want to, I'll put this out and then you can clarify if I've got something off here. Actually, I think that, I think Andrew also sent an email about this to them, but I'm looking at the section 50538, of the Title 18 for telehealth services. And what I'm trying to make sure I understand, I'm wearing more my University of Vermont Medical Center hat as I ask this, I guess more than NETRIC because we're getting questions.
Okay.
We do get, pretty continuously, we get requests for especially psychiatric services, telepsychiatry services from New York. And in our most recent one, our leadership contacted me to check on some things, but that was OMH. So I was able to clearly say, no, we cannot do telepsychiatry to OMH licensed sites because we asked that and we got very direct email back and they said, no, you have to be within state for an OMH licensed site. So my next question is, although they said, but that's just for OMH licensed sites. But if they're not OMH licensed, then like Article 28 or something, you could probably do it. However, I'm looking at the 50538 section of health department stuff, and
so the proposed regulations, right?
Yeah, I think I am looking at version 22.
Okay.
That's what I wrote at the top of it. Does define, it says the distant site must be one of the following locations: a hospital licensed under Article 28 of Public Health Law, such as inpatient emergency department or clinic, an Article 28 freestanding diagnostic and treatment center, federally qualified health center, a practitioner's office where patient care is provided, or another setting as approved by the commissioner or his or her designee. So my question is, I'm assuming that an out-of-state hospital like ours, like the medical center, even though I know I'm sure we see Medicaid patients from New York, but they come over here. But I would assume that means that somehow we participate in New York Medicaid. I don't know if I'm using the right lingo, but I don't know if we would be considered a hospital. We're not a hospital licensed under Article 28.
Right.
I would assume. I'm assuming.
Yeah, I think the way that would work for you is you say that you're working out of a physician's office.
Even though it's the hospital? Because I thought
we could clarify that with DOH. We could ask them that, but I think the sense, or at least the intention of DOH is to say we don't want a provider who is working out of home.
Yeah, right.
So they haven't made a restriction on state lines. They are thinking about providers out of state for OMH, but I don't think that's the sense for DOH.
Yeah, I guess that was my next question. It sounds like you've maybe interpreted it. It says a practitioner's office, and you're right, it does not say a New York practitioner's office. Right. And it also says a federally qualified health center, and it doesn't say New York.
Right.
So should we interpret that to mean it's not New York necessarily, that it is it can be out of state?
At least in all of our previous conversations with DOH, they haven't said no, that's a problem if they're out of state. So
Hal Smith is trying to chime in.
Oh, Hal, you want to make a comment about that as well?
Hold on, let me pull that up. Yeah.
Let's see.
I sent him an audio pin.
Oh, Hal, you got to enter that audio pin when you get it. So, is there anybody else from DOH on the line? Can you?
What name?
So I can't see the screen right now.
There's no Rayanne.
Okay. Maybe Peter Kaplan. You could unmute Peter's line.
Sure.
Oh no, Peter, you got to enter that audio pin. So that's a question we can ask Judy for sure.
Okay.
Peter, are you on? Can we hear Peter now? No? Maybe not.
I
Try
can't
again.
unmute him.
No? Okay.
There we go. Now I'm unmuted.
There you
Hi,
go,
Peter.
We can hear you now.
I sent in a question. Basically, I'm working with several third-party vendors, and they have interest in contracting here in New York to provide a range of mental health services, from just basic counseling to medication management with psychiatrists. My question was, how would they be paid? How would reimbursement for these third parties? Would they be billing the insurance on behalf of the client, or would the client be billing the insurance and keeping the reimbursement and paying the third-party vendor an upfront fee? That's one of the strategies we're doing right now with the SUNY system. They need mental health counseling, and so they're willing to pay for the services upfront with the expectation that their insurance plans, either student health or private health insurance that students may have, would then reimburse the university. Although several of the universities are not set up for billing, so they would rely on the third party to do the billing on their behalf and then remit back to them a reimbursement less a billing fee. But the vendor would be paid up front, either in buying blocks of time where a hospital or a clinic can purchase a block of time and then be responsible for scheduling patients, or there would be some sort of capitated rate that could be calculated across the North Country network. So I'm just curious if those provisions are now available, because there are third-party mental health companies that would like to contract.
Yeah, Peter, I think we have seen different models that have been proposed. So in some cases, like in our FQHC, for example,
I can't hear anything. Nope, no audio. I can't hear anything. There we
David?
go, I'm back. Hello?
David, this is Hal. Am I on?
Hello?
hey guys, we're back.
Okay, I hear you.
Sorry about that. We hung up by mistake. So yeah, Peter, we've seen different models that have been proposed. In our FQHC, for example, they're working with a third-party vendor who's actually going to become basically a part of the FQHC staff. The FQHC is billing and will pay the third-party vendor directly. In other cases, especially within primary care settings, most of the primary care settings are looking for vendors who will do billing. And so if a vendor isn't set up to do that, they're probably not going to be working with them. Some of the more hospital-based settings that we've worked with, hospitals, they're kind of looking at both. They always prefer that a vendor does billing. And largely that's, a function of the amount of work that presenting sites. So a presenting site has a lot of responsibility for, in the case of psychiatry, for example, or any behavioral health, they're doing a lot of work up front, basically for the specialist to show up and do the job. So they're hoping that vendors will appreciate that and then say, we'll take the billing piece. So those are kind of the models that we've seen. I think there's, any number of different ways to do it. You have to find a win-win for both the vendors and for the settings that are presenting patients.
Well, thank you, David. And certainly, should you want to pursue some, I have several vendors that are willing to negotiate any type of arrangement that is
Sure.
amenable to your end site. So, I think there are several different ways to offer this, and certainly would love to explore that.
Yeah. And I think we have a call scheduled for tomorrow or something like that, right, Pierre? So.
I'm not aware, but if we do, let me know.
Okay. All right. Yeah. So DLH, there isn't a limitation from DLH. Their regulations are largely focused on Medicaid, and they don't prescribe how the billing is done. OMH, however, does say that the presenting sites, if you're an OMH facility, OMH, those sites have to do the billing and compensate the hub site. So, all right, Hal, were you wanting to comment on something maybe? Hal, unmuted.
David,
Hey, Hal.
you got me?
Hi, Hal.
Hi. Sorry, I had a mechanical problem. And I lost track of the conversation. Sorry. I'll stay tuned for now. I wanted, when the person from UVM was talking about out of state, I agree. My understanding is the same as yours. If the psychiatrist, the provider is in a private office, as long as they're licensed and credentialed to practice where they are, that's not, that shouldn't be a problem. And the billing occurs on the end where the patient is. not
Right.
where the provider is.
Yep.
Sorry, I know that's old info, but
Oh, appreciate that. Do you see other comments there, Judy?
Yeah, Lowell Feldman,
Okay, Lowell.
he had a question, could provider billing be simplified for all telehealth services for DOH, OMH, OASIS, et cetera?
Well, Lowell, that would be the dream, right? And maybe we're headed there eventually. But currently it's still a little complicated.
Mm-hmm.
Can you unmute Lowell? Is he...
I did. I sent him a pin. Or he's...
Lowell, are you on the line? No, maybe not. Okay.
Yeah, it looks...
Other
He's self-muted and I can't
other
unmute
comments?
him.
Questions?
Avril George?
April, how are you?
The question, when is
She.
the proposed... Oh, I'm sorry. She. I'm new.
Yep.
When is the proposed regulation going to be finalized? I sent it an audio pin.
Yeah, April, on that question, we still don't know the answer to that. And frankly, the longer it's delayed, I think the better. Because again, some of those regulations are limiting. But it would be nice to have clarity around it. So we don't know when. I hope that in January, when we meet again in January, we'll have somebody from DLH who can comment on that. Anything else?
No other hands raised. Lawrence Care, what is the rationale for the just discussed limitations of site? Why is home not available? What is the concern?
Yep. So the concern there is around the privacy and security. So DOH is concerned about a provider who doesn't protect the patient's confidential information. So, even though the case of, using a HIPAA compliant platform and being in your car with nobody else around happens and is something that I know that providers have done before and have protected patient information. They're concerned about that. So what they don't want to see is a provider in an airport talking to a patient where other people could see that, or in a Starbucks or something, and the patient is seen or something like that. So.
Okay, the next question, I'm just going in order. Lowell Feldman, skilled nursing facilities have an interest in using telehealth for after hours and weekend coverage using their own medical groups. The restriction of the doctors having to be in the office is making this difficult. Is there a waiver for skilled nursing facilities to provide services with the physician not being in an office?
Yep.
Basically, Avril kind of answered the question, saying, unfortunately, no, they have to be in an office where patients are physically seen, which you just addressed.
Yep. Now, again, all of those regulations apply to Medicaid, DOH Medicaid, and if it's not a Medicaid patient and you're not concerned about billing or reimbursement, if like in a skilled nursing home facility, there's the potential for a contract. So if you want to provide telemedicine or telehealth to a skilled nursing facility, they're not saying it can't be done, saying it can't be reimbursed. So
we have a question from Pramod Gaur. I apologize if I messed that up. Can you please comment about Bill 5733, which authorizes PT and OT as a telehealth provider? I unmuted him.
Pramod, do you want to go ahead and ask that question? Or comment?
Yeah, I just wanted to see this. Can you hear?
Yep,
yes.
I can hear you.
Yeah, this is new legislation that was passed that authorized physical therapists and occupational therapists to be the provider for telehealth services. And I just wanted to know if you or someone in the audience has anything to let me know what that entails and when would that be effective?
Yeah, so we actually have some experience with that in the Adirondack region. There's a physical therapist right now who's doing e-visits, basically. So again, the regulations really apply to how reimbursement works. And so, it's focused, DLH regulations are focused on Medicaid reimbursement. So in our experience working with a physical therapist, she's doing follow-up calls, charging basically an hourly rate, and patients connect with her and they're basically charged by the minute. So she gets to see them, gets to interact with them, watch them do various exercises, confirm that they're doing them in the right way, and basically have a video consultation with her. So it's something that's possible and happening.
So is there a reimbursement for this?
So at least with Medicaid, there wouldn't be in that scenario because the patient is in their home. If they were presented from an approved site, then there could be Medicaid reimbursement. Private insurances would work differently. For example,
Okay.
Excellus or MVP or any of those other providers. And Medicare, the Medicare rules, stay the same so far. We're waiting on legislation for Medicare to change, but that hasn't happened yet.
Thank you.
You're welcome.
There's no other questions at this time.
No other questions. Wow, that was an exciting round, though. Thanks for that. Let's see. Is Mariah on the line? Looks like Mary.
Is it M-A-R-Y-A?
Yeah.
Yes. Send her pin.
Okay, Mariah, we've sent you an audio pin as well. We wanted to follow up with Mariah from Excellus on this question. There was a question that came out, I think from the Northeast Telehealth Resource Center, about the Modifier 95. So there's a piece of information in Excellus's policy that says they'll start using the Modifier 95 in January 1st of 2017.
I just need her to put in her pin and I can unmute her.
Yeah. Mariah, if you could just enter that audio pin, then we can tap into you. Let's see.
It's not working.
No?
Send again.
Well, maybe we could come back to Mariah. The other thing I just wanted to mention was the legislation that was, just recently passed, the ECHO Act. It was, passed both the Senate and the House and signed by the President, apparently, and also the 21st Century Cures Act. These both have at least opportunities for telemedicine moving forward into the future. Certainly the ECHO Act, we've had folks from the University of Rochester Medical Center who run the ECHO project so far in New York State. They've expanded into a number of different areas with ECHO, and so we're excited to see further development in the ECHO project area. And then the 21st Century Cures Act, which was signed by the President as well, that one, basically, it looks like it opens up opportunity for research within Medicare. So the interesting thing about Medicare is that Medicare, at least around reimbursement, has always said we need data to support the idea of claims and what the number of claims would look like, and is it, you know, is it going to cost too much money for Medicare to expand the presenting site limitation? So again, right now, Medicare says that if you're in a metropolitan statistical area, they will not reimburse. And in order to expand that, they say, we need more data. And so we respond back to Medicare and say, well, you know, what data do you need? We'll show you what we got. And they say, well, we need Medicare claims data. Well, we don't have that because you don't allow it. So it's kind of one of those catch-22s we go back and forth on. But this Cures Act, at least, it looks like it's expanding the opportunity for us to show more data and at least see Congress maybe move on Medicare. So, any thoughts on that? Questions, comments? April?
I've unmuted Andrew.
Andrew. Hey, Andrew.
His hand up. I apologize.
That's okay. Hello. I have a question, but it's unrelated to what you just talked about, David.
Okay.
Another New York.
Go ahead.
It's another New York. Okay, another New York DOH question that I haven't had a chance to confirm with Ray Ann yet. So we've received a couple questions about teleradiology, and I understand that DOH is getting ready to publish an updated radiology regulation at the same time they publish the telehealth regulation that will allow teleradiology, store and forward services, assuming they get the CMS state plan amendment approved. But what I haven't been able to figure out is what prevents sort of store and forward radiology at this point. And I wonder if anyone has any insights. Is it that the physician has to be located in the state and this regulation would expand beyond the states? Because it does specifically say that the physician can be located anywhere in the 50 United States.
Well, it is interesting because in some of the earlier draft versions for the DLH regulations, they included teleradiology, and at one point they at least said that no, they have to be in New York State, and I think that was obviously changed. But some of the versions that DOH had for regulations basically exempted radiology, or said, you know, that's going to be separate from our telehealth regulation. So that's the only thing I really know about it. I don't know where they're at now.
Okay.
So that'd be a great question to bring back. Maybe we can have them speak to it in January.
Sounds good. We'll add it to the list.
Okay, thanks.
Howard Rice.
Howard?
Hand raised. I'm sending him a pin.
Oh, hey, Howard, you're going to have to enter your audio pin so we can unmute your line.
Maria's still, Mariah.
Mariah?
Still not. Oh, now I can unmute her.
Mariah, can we...
Are you able to hear me?
Hey,
Yeah.
there we are. We can hear you.
Hi guys. Sorry. So I wanted to just respond to the question about the new modifier 95, and also to clarify that while that new modifier has been added to our medical policy, it is we are not editing based on that modifier at this time. We haven't seen CMS take a position on that, so we've shared it with many of our partners just as an FYI, and you know, also including the new place of service code. But again, at this point in time, the health plan is not editing based on the use or no presence of that modifier.
Great. Thanks for sharing that. I think that'll be really good news to folks around here. So, any other updates, Mariah? Anything else you'd want to share with us?
Someone just muted her.
Oh,
there we go.
Go ahead.
My only update would be just a reminder that as of January 1, that our Medicare Advantage members will have the remote access technologies benefit, which means that any providers may provide our Medicare Advantage members with a telemedicine visit and would be reimbursed at 100% of the fee schedule. And I heard earlier that somebody had a question specifically related to the skilled nursing facility environment, and we certainly see that as an opportunity to maintain a treat-in-place culture and to prevent those acute care transfers, especially if a provider group, if you can use an existing provider group to provide those visits. And if that's something that somebody wanted to explore more intensely, please feel free to reach out to me, and we'd love to have that conversation.
That's great. Thanks, Mariah. Appreciate that.
Sure. Thank you for the opportunity.
Yeah, any other questions for Mariah at Excellus?
Let's see. Lowell, your line is unmuted.
Oh, great. Thank you. Can you hear me now?
Ken, Lowell, how are you?
Great. I'm live for the first time. Great. Feeling good. All right. Thank you on that. And we've been doing meeting with a lot of skilled nursing facilities and associations. I know the final rule isn't out yet on the location of the doctor, but hopefully there's room to combat that requirement of being in their office, because doctors are not just sitting around their office, nor do they have staff after hours sitting in their office waiting for the urgent calls, which is the main part of the meeting. And I mentioned this to Joan Sickard in the department. We had a meeting with them on Halloween live and did some telemedicine presentations as well. The response is, well, it's not cast in stone. So maybe there is hope for that, because I am concerned, say for a Medicaid patient in a nursing home, Medicaid only, where now you're asking a doctor to bill the facility privately, and they never liked what used to be known as double dipping, yet they're almost imposing it on us to cause an additional cost of facility operations, and a doctor basically billing a facility for caring for a full Medicaid patient. Mariah, thank you on the Excellus and the Medicare Advantage. Hopefully I can get your contact information as well and continue this discussion, because we are making headway in the industry, because it is certainly going to be the only avenue available to reduce readmissions and provide quality care back to hospitals, and also in the area of assisted living, transitional housing et al. To follow this up. So thank you for unmuting me, but as far as questions, we'd love more answers, especially. And I guess it was asked already, but no date yet. And Halloween, they didn't know when it was coming out on the 23rd division for public comment. By the way, I did try to supply the comments that you provided, David, to us, and handed it to them. They said, well, we'll look at it, but unofficially, because there wasn't up for public comment yet. All right, fine. Yep. And certainly I would like to keep posted on that. The mental health services also. I do have a curious situation, actually. If an FQ, fairly qualified healthcare center, was providing service to a skilled the nursing, and does that physician also have to be in his office or just affiliated with the FQHCA? Or is the sitting in the office mandated on everybody?
I'm not sure I quite understand the question there, Lowell.
Have an FQHCA that's interested in providing services to nursing homes. So would their doctors also have to be sitting and residing in the FQHC headquarters or home office? Or could, if they were on staff with the FQHCA, would that be sufficient?
Well, so they could be on staff, but they need to be in their office in order to provide care and be reimbursed by Medicaid. Although skilled nursing facilities typically aren't, it's possible you could have a Medicaid patient there, but they're largely Medicare. And so as long as the Medicare facility is in a rural setting, a non-metropolitan statistical area, it's likely that Medicare will reimburse that.
Okay, well, I know Medicare, many, once the Medicare expires and they either go on Medicaid or now Medicaid managed care, they're long-term on that. But I thought there was waiver for skilled nursing and for the billing on rural topic for skilled nursing and FQHCAs.
I'm not aware of that, but it could be. If you find some data on that, Lowell, I'd love to hear about it. And I did want to mention, Lowell, too, that I'll send out Mariah's contact information. She shared that with me before and said we could publish that. So in my summary today, I'll send out Mariah's contact info. So.
Okay, thanks. You can mute me now.
Okay.
Hal's had his hand raised for a while, so I'm going to unmute him. Hi, Hal.
Hey, Hal? Do we get
I've unmuted him.
Can you hear me?
Yeah.
Yes, hi.
Hey, again, the hand was raised to a question a while ago about radiology, but I mean, as you know, for example, we provide EICU from the Westchester Valhalla campus, totally monitoring the ICU up in Mid-Hudson in Poughkeepsie. And there's exchange of radiological information but a part of that, and it's Article 28 to Article 28. I don't remember who asked the question, but I don't know why is that still a prohibition.
Yeah, I think Andrew Solomon was asking the question about that. So, Andrew, do you want to clarify that question, or?
Well, so I guess that I may be asking the same question. So I know that there's a regulation being proposed to allow teleradiology, and it is in the draft I have for the telehealth regulations. It is mentioned in that, and then there's a separate regulation which would add some language to radiology regs to allow teleradiology and would allow physicians to be anywhere in the 50 states. But I don't really understand what the current limitation is that requires this change in regulation.
All right, we're thinking along the same lines then. Yeah, exactly.
So I know that there are hospitals in our area that are doing basically teleradiology. They've been doing it for years.
Right.
And their providers are in Australia. So I don't know what the issue there is.
Yeah, and I'm sure, as many of you know, Medicare doesn't consider teleradiology telehealth, and it's excluded from the telehealth regulations. So to group it together is a bit unusual, I think.
Yep, agreed.
And David, I did have another comment on the previous question about FQHCs and skilled nursing facilities.
Yep.
Just wanted to mention there is a Medicare regulation that stipulates that FQHCs and rural health clinics cannot serve as a distant site. The physician cannot be located, or the FQHC cannot bill for a distant site telehealth service.
So they can. I think that doesn't that say though that Andrew that if the presenting site is the FQHC, they do billing. So I'm the way I saw that was that it was just related to when the FQHC is the presenting site, and not the hub site. Have I got that confused, or I could?
I think we could pull it up. I think it's part of the Medicare benefits manual for FQHCs and RHCs that states that the FQHC cannot contract or employ the physician who's providing the specialty services or the services from a distant site.
Huh. Well, I wonder if Cyrene's on the line. Do you see Cyrene Garcia? Because we should ask Cyrene and Mary Zelazny about that. So they're pretty active with the FQHC, and I'm pretty sure they contract with other providers. So I don't know. Maybe it's not Medicare. Maybe it's just Medicaid or something. Another question for January.
Yeah, and they would certainly know the language. I just pulled it up. The exact language says RHCs and FQHCs are not authorized to serve as a distant site for telehealth consultations, which is the location of the practitioner, and may not bill or include the cost of a visit on the cost report. and that includes practitioners who are employed by or under contract with the RHC or the FQHC.
Huh. Could you send that along, Andrew?
I was just about to ask. I want to see that.
Yeah, I'd like to. It'd be great to see that. So.
Yep, absolutely.
And then I'll share that with the group and see if. So Julie Horton, also from the North Country Family Health Center, you know, we could get their input on that as well. All right.
It's fairly recent. I think it went into effect initially at the beginning of 2016. Or no, I'm sorry, at the beginning, beginning of 2016 it looks like. So it's fairly recent.
Yeah, yep. Okay.
Howard Rice has had his hand up.
Howard?
Yeah.
I think you're unmuted now, Howard.
Okay, can you all hear me?
Yes,
Yep.
we can.
Sorry about the wait.
No, I appreciate it. Howard Reese with Healthy Practices. Just wanted to provide a little clarification about the current practice of teleradiology. There are approximately 100 commercial teleradiology providers in the country. Most of them are able to provide service in New York State as long as one of their physicians is licensed in New York State. So if there's any new regulation coming down the path, that's going to be of strong interest to all of those commercial teleradiology companies. You mentioned the teleradiology being offered from overseas, specifically from Switzerland. Since the year 2000, Nighthawk Radiology had facilities both in Switzerland and Australia. The CMS rule is that a physician can provide a preliminary report if they're overseas, but for a final report to be issued and for it to be acceptable for CMS billing, the physician needs to be on U.S. soil and also licensed in the state where the patient presents. So, more than happy to provide any other information with regards to teleradiology. Been playing in this space for about 10 years.
Awesome. Thank you, Howard. Appreciate that.
Hal, you had your hand raised again.
No, I think that's from previous. Sorry.
Okay. Trying to keep up. Andrew has his hand raised again. Andrew, you're unmuted.
Also previous. Sorry.
Okay. I don't know why those aren't going away when I click on them.
Is that Hal again?
Yeah, I think it's just not going away. That's all. That was Lowell. That's from.
Yep.
Oh. Lowell, you're unmuted.
Oh, I didn't have my hand raised this time, though. Let me check.
Oh,
okay.
It's showing it was. I apologize.
Yep. She clicks on it and it comes back on.
Yeah.
So.
There's no other questions right now.
No other questions?
Nope.
All right. Well, you know, one kind of final thing I wanted to do was see if anybody wanted to take a stab at this, you know, couple of questions I asked. You know, what you saw, number one, as, you know, one of the greatest achievements for telemedicine in New York State last year. And then as a follow-up, you know, what are your expectations for telemedicine in New York State next year? And if you want to, you know, add some thoughts to that, now is your chance. So just raise your hand and anybody want to take a stab at it?
Lowell just raised his hand.
Lowell, you want to give it a try?
Well, yeah, I go back to the billing and good old Medicaid. I think it would be nice to hold a caucus with the Department of Health, Office of Mental Health, and OASIS, the three big players, and make them aware of the obstacles that they're putting in place are going to actually end up costing them additional funds in hospital transit and the lack of ability to do remote patient monitoring, and people get paid by the system. So that would be the hope for the future.
That's great. You know, Lowell, I'm really glad you mentioned that because we've actually tried to. So we have folks from DOH on the Learning Collaborative. We have folks from OMH. fairly recently, I've reached out to Oasis, and we're trying to find somebody to connect with this learning collaborative from Oasis. So if you have a contact there, maybe you could send them an invite to participate. That'd be great.
I'll try my best to do that for you.
Thank you, Lowell.
Peter Kaplan said Parity Pay. Maybe Excellus will start paying Parity.
Yep, Parity Pay. You know, I'm excited to have Excellus participating, and you know, grateful. I think that was one of the big successes from last year, was to be able to you know, have a really good dialogue with Excellus to say, for the projects that we've already had up and running, you know, keep paying 100% instead of shifting to the 50% payout. That was pretty important to us, at least.
Another comment, Averill George, I think New York State has actually lost ground with the proposed new regulation.
Averill, you wanna say something about that?
I sent him a
pin.
pin.
Audio pin, Averill. Got to enter that audio pin. But
in the meantime, Andrew Solomon has said looking forward to the 2017 Netrix conference at UMass Amherst, May 23rd and 24th.
Yeah,
too.
Good promo there, Andrew. Yep, Netrix conference coming in May. That'll be important. Andrew, you want to kind of give the promo? Go ahead.
Yeah, we'd love to see everybody there. We're just getting ready to share more information next month about the agenda. Working on some exciting keynotes, hopefully, but more information to be released in January when we also announce the attendee registration. But just sent out our sponsor invitation today to try and get some interesting folks there to show off their wares.
Okay, Averill is now unmuted.
Averill, go ahead. Let us have it.
Yeah, I think we lost ground in having overregulation, where they want the physicians to physically be in a place where there's, even though they're not seeing any of the patients that are at that same place. But I think that right there, that overregulation, I don't know what happened. If it was, we had too much money to pay lawyers or something, I don't know. So that was where we lost ground. So
yeah.
That's it. But the Excellus thing is good. You know, the payment parity throughout in all those laws that they came with, those were good. The others, this one in particular, I think is disappointing.
It is disappointing.
I'll just stay tuned to see what happens.
Well, we hope to see a lot of, you know, developments in the next year. That's one. You know, the payment parity, we expect to see that legislation proposed again, where it would be not just coverage parity but payment parity. That will make a huge difference. And you know, like we've seen with OMH, OMH has taken some time to make progress with their regulations. I think that will be the case with DLH. We'll take a few steps forward, and maybe it's not everything we want it to be, but I think that the direction is positive. So eventually they'll be reimbursing physicians who can protect privacy, protect patient confidentiality from the privacy of their home offices. I think that'll work. So we'll see.
Lawrence said, your persistence in organizing these conferences is a highlight. The challenge and need is to have the intent of the telemedicine law instituted.
Well, I appreciate your kind remarks there, Lawrence. Appreciate it. Thank you.
There's no other questions or comments at this time.
All right. Well, thanks everybody for participating today. We'll send out kind of a summary like we always do, a couple bullet points with a link to the recording so you can tap into this again. And shortly after today, maybe in the next couple days, I'll send out a new invite to the webinar so that you can register for next year's webinars. So again, the third Monday of every month, that's when we meet, 2 o'clock. We'll still have lots to talk about coming in January 2017. So I'm going to say Merry Christmas to all, and to all a good night.
Yes.
So thanks for joining us. We'll look forward to seeing you next year.
Happy holidays.
Bye-bye now.